I am going to turn the presentation over to Emerson from Philips Respironics and have him introduce himself and proceed with the presentation. Go ahead, Emerson.
Thank you so much, Rose. Good morning, everyone. Thank you so much for joining us. We're excited to share a new opportunity, a new product with you, and looking forward to discussing this as we go along this morning. Joined with me is my friend and colleague, Andrew Blancas. Andrew joins us from Salt Lake City, Utah, and I'm from Mobile, Alabama. We're both the territory managers for NightBalance, the new sleep positional trainer with Philips Respironics. So thank you again for joining us this morning. Some things we're going to try to talk about today is defining what positional obstructive sleep apnea is, the clinical evidence surrounding it, some therapies and some options that we have with it, and then review some clinical and business opportunities for providing therapy for positional obstructive sleep apnea. So with that, let's just a quick review of what sleep apnea is. You guys have all probably seen this cutaway before, but it's a picture of obstructive sleep apnea. On the left, we see a normal airway, normal breathing. On the right, that collapse of the velo and hypopharynx that occludes the airway. That is, at the end of the day, what we try to treat with CPAP. Forcing air through either the nose or mouth or both, we're able to create that pneumatic splint that opens that up to give us normal breathing. And we know, we've seen these numbers before. There's a lot of people that have obstructive sleep apnea. And with that, the problem is that 80-90% of those that have it are undiagnosed and untreated. And of the 80 to 90% that have OSA, there's a percentage that still have that complex sleep apnea, central sleep apnea, that continue to need, technologies like ASV or AVAPs to treat them. But we're going to have that group that, fits into this positional obstructive sleep apnea category. And, with that in mind, it's a conversation that's been going on since probably the early 80s. Dr. Cartwright in 1984, she was able to really identify what positional obstructive sleep apnea was. And at that time, one of the things that they were thinking about is, head position and body position, and wondering if any of that would weigh in on, the severity of OSA. And what Dr. Cartwright was able to determine was that people who were sleeping on their sides, who had OSA, had less sleep apnea than they would on their back. And she gave us some criteria. And basically, anyone who fits the description of positional obstructive sleep apnea is going to be someone where their AHI on their back is twice as much as that on their side. And that makes sense from the standpoint of saying it would be positional, that a lot more of their apnea would be on their back than they would be on their side. But she gives us a bit of a measure, something that we can wrap our heads around to say, okay, this is what this might look like. We break it down a little bit further, and with this schematic, we can see that what she means by this is someone that maybe has an AHI of 30 on their back and an AHI of 15 on their side. And just to remember, AHI is apnea-hypopnea index. That's the number of apnea and hypopneas that somebody might have within 1 hour, to give us just an easy picture of how severe they are. So if we're thinking, though, that, is this somebody that has an AHI of 30 and 15 a candidate for positional therapy? They could be, but it's really going to be more along the lines of someone who has exclusive POSA or exclusive positional obstructive sleep apnea. Someone with an AHI of 20 on their back and 10 on their side might fit a little bit better into that category. They're the kind of person, you've seen them before. They're the ones that, they come in, you see that their AHI isn't that high, and they get on CPAP and they hate it because they didn't have that great epiphany. They didn't have that moment where they thought, man, my life is so much better with CPAP. They really struggled. And, of course, we told them, you're going to have all these horrible signs and symptoms if you don't do it. And they do it out of fear and because we warned them. But the truth is they hated it. They're not having that great life change we hoped they would have. So they tend to struggle with it. And there's also the group that didn't qualify for anything. And so they're told that they need to find some other therapy. So how many people are we thinking about? Well, when we think about the total group of positional OSA, we have this large group that, just has positional, but the exclusive group is really is a small subset of that. About 36% of those with positional are going to be exclusive. They tend to be the type we're talking about. They have a lower AHI, have a lower body mass index, so they don't typically fit the stereotype of what we see with sleep apnea. So lastly, when we're talking about prevalence, just to get a picture of what this looks like, the majority are going to be those with mild OSA. We will have some that are moderate, and we will have some that are severe. And we can talk about some strategies on how we can tackle those together. So when we think about treatment, we see these pictures of all these different things. And if you go online and begin to search for treatments for positional sleep apnea, a lot of these things come up. But when we think about the one right at the top center, the tennis ball, that's probably the one that's most notable. The tennis ball technique was basically, coined by a German physician named Koenig. And the idea was of having this little contraption on the back of a T-shirt so that when somebody rolls against it, they would naturally roll back. The challenge is that it is uncomfortable. It also doesn't really fit in their life. And, when we're thinking about why people sought out a sleep doctor to begin with, one of the things is they're excessively tired during the day. And so now we're having them roll against an obstruction, whether it's a tennis ball or something else. It's something that's going to wake them up. So they're never really able to acclimate to it. And lastly, there's no way of measuring it. No real clear way of measuring for most of the things on the picture we saw, how to measure adherence and compliance. And as we think about where we are with outcomes-based medicine and value medicine, outcomes matter. Measuring matters. Having the download matters more than it ever has in healthcare. So when we think of positional OSA, we're thinking of a group that's 36 to 47% of all OSA patients. Many of them did receive CPAP first, but as we know, they tend to be non-adherent, 20 to 40%. So it implies that as many as 20% of your OSA patients might fit in the category of having POSA, positional OSA, that are non-compliant or not adherent with their CPAP or bi-level therapy. So challenging us to do this. So addressing these challenges, non-adherence is a barrier to both traditional OSA therapy and positional devices. At the end of the day, part of what makes them not adherent is the device, the therapy they're choosing. They never acclimate to it. They never accept it into their lives. They struggle with it and eventually quit. And that's exactly what we don't want them to do, because them quitting is going to mean not only they're excessively tired, but they have all the other issues that are, associated with untreated sleep apnea. So with that, that gives us a little bit of an introduction into what we're dealing with positional OSA, its prevalence, kind of its background, how we got here. And what I want to do is just hand this over to my colleague, Andrew, so that Andrew can take us through what the NightBalance positional trainer is and some of the data behind it. Andrew?
Yeah, thanks so much, Emerson. As you can see here, this is the Philips NightBalance Sleep Positional Trainer. Our lovely positional model there wearing it, so you can get some perspective to the size of the device. But how does it work? So the patient falls asleep in whatever position they desire. After roughly 15 minutes, the device will activate. Now, if at any point in time the patient is on their back, during that period of time, it'll administer a gentle vibration, cueing the patient to turn to their side. Now, one of the things that you can see here on the slide is it regulates the intensity of the vibration based off of their sleep behavior. So with this device, there are 10 different vibrational intensities to ensure that the patient does respond to that stimulus, but also 5 different vibrational patterns. One of the things that we want to make sure is they don't become desensitized and not respond to the device as a whole, and it's inadequate in that regard. One novel approach that this device provides is the Adaptation Program. So there is an analysis phase initially with 2 nights where the NightBalance simply monitors the patient and records what their positional disposition is if left to their natural tendencies. So we want to get a baseline metric and really call out a lot of those patients that self-report, no doc, I don't sleep on my back, it's not a concern. So we actually want to show the patient how much they do sleep on their back. Next, there's a build-up phase. That takes 7 nights, and it's sort of a titration of sorts where the device is identifying what intensity setting is required to cue the patient to roll to their side and be effective in that, and also just kind of a lead into it that we're not unnecessarily provoking the patient or causing stimulus that would cause an inability to return to sleep. On the 10th day of therapy, the device is in a full therapy treatment mode, and that's where the patient really is getting the full benefit of the NightBalance. The indications for use, though, are not entirely limiting, but it is a scripted device. This is an FDA Class 2 device. It is intended for an adult population, and like Emerson said, we really adhere to that positional OSA definition of that their supine index is roughly double or more than their non-supine, and their non-supine index being less than 20 to ensure that they are receiving treatment. The contraindications for the device are pretty obvious as well. If they're using a medical aid that can be affected by a mild vibrational stimulus on the chest, then that's definitely worth consulting your physician to see what that interaction looks like. Additionally, if the patient's required to sleep on their back because of other medical conditions that need to be considered, for example, a shoulder, back injury, or arthritis, then definitely that makes it more of a challenge to use this. And the last here, if they're only able to sleep in an upright position, we can kind of see how that would be problematic because the patient's not supine to begin with. However, what is the treatment suitable for? There are different applications here. So for the newly diagnosed patient with POSA that's just not even willing to entertain CPAP as a treatment approach, this could be an alternative. For patients that are non-compliant to CPAP, this is a great alternative. Additionally, there are other interventions like surgery, hypoglossal nerve stimulation, UPPP, things like that ilk where there may be residual events, particularly when the patient sleeps on their back. Lastly, there is this opportunity for combination therapy when used with CPAP or mandibular advancement devices where it improves both of the therapies' outcome as a result of being used in tandem. Now, some of the additional features that this device provides that, historically those mechanical devices weren't able to is that feedback. So first of all, we have a patient dashboard, and this is really just kind of a simplified measure of what's important to the patient. Average time spent supine, which is comparable to an efficacy metric because we understand if the patient's not on their back, then they're not experiencing apnea. So the lower that value is, the better off we are. Average usage time, again, a compliance metric. We want to make sure that the patient's using it for the entirety of their sleep session if possible. So that's a great thing to know. And then how well is the device working? There's this last item here, 87%. That's the number of reactions to the vibration. So when the patient is, given that gentle vibration, we want to see that they did, in fact, turn to their side, and if not, to log that as well. The other side of this is the physician portal, and obviously physicians probably want a little bit more detailed data to better treat their patient should they not respond or should we need to show them kind of different aspects of their care. Now, the periodic view shown here is sort of a trending window. We want to see what their baseline was, where they started, and how they're evolving with the therapy, how they're responding, and they're going to start being trained. They're going to learn to sleep off their back as this device is regularly worn. The next view is the day view, and this is kind of a detail view that gives a full positional breakout to the physician. So if they're inclined to see left side versus right side, prone versus supine, even upright, we're able to provide that fidelity, that level of granular data to the physician should they want to do a deeper dive. The last view here is the dashboard, and this is essentially the same view that the patient has available. This is great for the physician to show the patient just in a summary type perspective in a clinical follow-up. So again, those key identifiers that's, core importance is primarily to the patient. Now, there's a body of clinical evidence that supports this device. Even though it's new to the USA market, this has been trialed significantly. It's been published in 10 peer-reviewed medical journals, the bulk of which is comparing it to other treatment options, oral mandibular devices, making sure that compliance and efficacy is on par with an already established class of device that treats sleep apnea or positional sleep apnea, but has obviously its concerns, as Emerson noted. Now, one of the foremost claims, the evidence that we want to identify, is that this is a viable long-term solution to control the patient's AHI. That is historically what's plagued this device or class of devices, is patients generally don't tolerate it outside of a few weeks or months. So these were surveys following up on NightBalance patients on an average of 2.2 years, and it reported very consistent results. As you can see here, patients experienced less periods of choking or fatigue or cessation of breathing, gasping, commonly reported from an untreated sleep apnea patient. This is resolving that. The patient in numerous capacities has ability to characterize that they're feeling less sleepy or less fatigued. Conversely, more refreshed during the day. So very positive responses from the device 2.2 years after the introduction of the therapy. And definitely the most recent study that we want to highlight is the POSA study. This was a prospective multi-center randomized crossover study comparing NightBalance to AutoPAP. Again, this was identified for the POSA population, but how the study was conducted is they did a 6-week trial, either starting with AutoPAP or the NightBalance, and then after that 6 weeks, did an additional 6 weeks with the alternate therapy. The primary endpoints that we are after or interested in, again, are efficacy and adherence markers, but with that, we wanted to see if it was non-inferior. And how that's defined is that there was a less than a difference of 5 in the AHI point. Additionally, adherence, we want to make sure that the patient is using it as much as their AutoPAP. And so a pass metric in that regard is a 45-minute difference. Well, here are the results. So you can see on average, the AHI for the NightBalance was 7.29, on an AutoPAP 3.71. So slightly lower on the AutoPAP, but definitely still fell within what we would consider a pass, in that the mean difference between those two AHIs is only 3.6. Where we really were excited with the results here is the adherence aspect. Now you can see here the patient was using their NightBalance roughly 58 minutes more than the CPAP, or AutoPAP, sorry, where they were only using it 4.8 hours, we were at 5.8 hours. And so that's really reassuring to know that our patient is getting more quality sleep with our device versus traditional AutoPAP. The other outcomes that came from this study, not as impactful, but still very important, is that sleepiness was similarly improved across both devices. So subjective symptoms were abated. A greater proportion of POSA patients felt the NightBalance device was easier to use, easier to adjust to, and more comfortable. And that's pretty obvious as to why that may be the case. Being worn in a belt across their chest, they don't have to worry about mask fitting concerns, pressure intolerance concerns, or humidity concerns that still continue to be a concern for AutoPAP use. But the really leading conclusions that we need to take note of is that NightBalance as a treatment resulted in a non-inferior treatment efficacy. It was on par with AutoPAP and promoted greater adherence. So it's a very easy conversation to have if the patient can't tolerate their AutoPAP or CPAP, that this is something that's going to work for them as well, should they be a candidate and be in that POSA category. We do have additional POSA education. If you'd like to go and do a deeper dive into these studies, they are available at www.mycme.com. And as I understand it, we're going to be sharing this presentation afterwards. So feel free to go in here and get a deeper perspective of the other studies that have been performed showing that NightBalance is definitely a viable option or an alternate to these other classes of devices. And that takes me back to Emerson, showing you not only how NightBalance is a very effective treatment, but what does that mean for you and your business? Emerson?
Thank you, Andrew. I think, just to rehash where we've been, we talked about sleep apnea. We talked about positional sleep apnea and where it fits in the larger conversation around sleep disordered breathing. But we've also reviewed the NightBalance and the clinical data surrounding it. So we painted a picture of kind of the problem that exists today and how we think we can solve that. But then the question is, okay, well then how do I apply it? How do I fit that into my business and make it work for me, my colleagues, my business, and the market that I serve? Right now when you think about sleep, we've got a lot of things that we sell. In your business, you're looking at interfaces, you're looking at both the standard machine and the travel machines like the DreamStation Go, and the heated humidity, all of these things, with the dream wearers serve that purpose of not only serving your community and your market, but driving your business. But what if the patient is non-compliant? You've got all these things and all of this investment that you made in your business, but then you have to ask yourself that question. You've got this patient, you've done all this marketing, you've generated, all this leads and business into the funnel. And, with that initial setup, you certainly have that partial realization of your return on investment. But if the patient fails, then, we've got a challenge. What you're really wanting is them to be the repeat customer, be a part of your ongoing family, and realize that no matter what they need for their health care, particularly their home health care needs, you're able to take care of that. But there's that challenge. You've got this group that we'll just call them lapsers. They're those ones that become non-adherent. They don't continue with your business. And you begin to wonder, okay, well, what happens to these patients? What can I do with these patients? Maybe they weren't a candidate for BiPAP rescue. Either way, they end up being a challenge because they fall off. They no longer buy mask replacement. They no longer, are part of your fulfillment program. So they're no longer on therapy. Maybe they choose a mandibular advancement device or surgery or no action at all. So knowing that about 34% of patients can fall into this category, we can begin to wonder, okay, where does the opportunity lie? And that's where we see NightBalance, potentially completing the circle. If you think about patients that fall into this non-adherent category or just positional all the way around, part of the challenge there with these kinds of patients is that, if they are positional and didn't need CPAP, you never see them. Maybe the doctor sends them to Amazon or somewhere to buy a product, or to, down the road to a local store to buy a tennis ball. In reality, you would never even meet these people. But when we have those that fall off of therapy because they were not adherent, and we know that they were positional, this certainly, reveals a unique opportunity for your business where NightBalance can fit into your portfolio of solutions. With that in mind, let's take a step back and think about some of the things that Andrew had mentioned on who is our primary target. But we certainly look at this non-adherent patient. The patient that went on therapy, they hated it, it didn't fit in their life. It could even be a patient who looks at you, and when they see CPAP and they see the mask, and they just respond with, there's no possible way I'll ever wear that thing. Is there anything else other than a mask that I can use to treat this sleep apnea? There could be other patients as well, as we think about those that are looking for a combination therapy. Perhaps they're already on CPAP and the pressure is extremely high, and when reviewing their study and the data that you have, you find that the high pressures happen when they're on their back. So there's ways that we can begin thinking about your existing base of business as an opportunity to look at patients who might qualify or might be interested in this product. But, when the newly diagnosed patient, we're thinking, like we talked about before, that mild to moderate OSA patient where their supine AHI is twice as much as is what they would have on their side. And the study clearly can show that they have positional OSA. and they prefer a non-invasive solution, or at least a non-mask solution. Others that might benefit from it could be those that are post-surgical. And of course, we talked about those that would use combination therapy. The real point of this slide is really just say the opportunity is really broad and wide of the kinds of patients that might benefit from this. So if we break it back down again, we've got the exclusive patient that would never qualify for CPAP, but still is symptomatic with their OSA. We've got the patient that qualified, but, absolutely couldn't tolerate it. Maybe they were just simply non-tolerant, but they refused the therapy. Then those that we might combine therapy with their existing CPAP or the oral appliance, so that what we're able to do is treat them better, make the overall experience better and more efficacious for them. So it really opens up a lot of different conversations we can have about the product. So as we begin to sum this up, we've got a product that's clinically proven when compared to auto CPAP, our gold standard of care. It's a mask-free therapy for people who simply can't tolerate having a mask on their face. This is going to give us better adherence, and it's going to be able to treat them effectively. As Andrew stated, it does require a prescription, which certainly is helpful if they want to use their HSA account to pay for it. As built for travel, the case is very durable, allows them to travel with it, and pack it or whatever they need to for their airline travel. As Andrew said, it's a customized therapy. Using this adaptive algorithm, it's a palm-sized device, wore comfortably across their chest. It's designed to be quiet. The vibrations are not designed to wake up the patient or wake up their bed partner. The adaptive technology allows them to literally adjust and adapt to the therapy. Because if you think about all the other options most people have, there are things that are going to disrupt their sleep. They don't fit in their life. As a matter of fact, some of the doctors we talked to in the beginning, as Andrew and I began to work with this device, we would ask them, okay, what do you like about this for your patient? And it wasn't a very scientific statement, but the answer was simple. It fits in their life. And that's a big deal. But even then, the fact that it's adaptive and it learns the patient and it fits in their life, it also gives us data. And that's so important in this value medicine world we live in, where we absolutely need data to know if a patient's using therapy and if it's effective for them. And for your sleep labs that are measuring that, they're needing to be able to measure, that they have the right diagnosis, they have the right treatment, and they have the right follow-up. And this fits into that model that they're having to work in. So we begin to think about this from an operational standpoint. One of the things is just thinking of what the patient has. And backing up here is they simply need to log into the website, fit the belt around their abdomen or their chest, slip the device into the sleeve, go to sleep, and then recharge it the next day when the data uploads to the cloud. That's it. So when we look at what you guys spend on mask fitting and the CPAP setup, this is all the patient has to do. Create their account, fit the belt, make sure the device is charged, put the device into the belt, sleep soundly, enjoy that, and then return the device to the cradle so that it recharges and uploads to the cloud so that they and their physician can have the data. So how do we win together? Well, as we talked about, we've got lapsed patients, these non-adherent patients maybe that quit therapy that could be candidates for this. Maybe you look into your database and look for those patients that were not adherent, that maybe were positional, and begin to reach out to them and offer them this solution as a way to solve a problem they were seeking a solution for in the past. One of the things that is really important about selling this is really breaking this down so that patients can appreciate the value you're providing them. One of the value pieces is how we stand behind it with you with a 30-day money-back guarantee. So as they're looking at this and they're struggling with, how is this thing going to fit in my life? I'm making this investment. It seems like a lot of risk. Well, we try to mitigate that risk by having this 30-day money-back guarantee. We've encouraged, working with them on a monthly payment, even telling them, listen, it's only about $69 a month. Something simple like that really puts it in a bite-sized category, allows them to really wrap their arms around it and understand how it's going to fit in their life. both financially and clinically. And so as they look at buying it and you get a prescription for it, it's really just selling it, getting it in their life, and moving forward with a new kind of therapy that is proven to be efficacious in controlling their AHI. So with that, we've got a lot of tools and assets to help you sell, to help you educate, to help you market this technology as a part of your business. And these can be found through your local account manager with Philips Respironics that will want you to work with. So with that, as we summarize, we've got technology that works. It engages with your patient, allows the patient to see their success, and provides something new for your market. With that, we want to thank you so much for sharing.
I am going to open it up. Thank you both, Emerson and Andrew, for this wonderful presentation. I'm going to open up the Q&A. So if you go to your screen, if there's anybody that has any questions, you can see on your screen an opportunity to participate in the queue. Right now, we do not have anybody in the queue. You can hit #6 or click on the Q&A button on your toolbar. We'll give it another half a 30 seconds. All right. Well, hearing none, again, thank you to everyone who participated in today's webinar, and we thank both Andrew and Emerson and the Philips Respironics folks for the time and their information on this webinar. We will follow up with everyone who RSVP'd with a copy of this presentation, and as a reminder, the recording will be posted to the MAMES website within a few days. We do have one question, it looks like. Go ahead. There's a person. Go ahead.
Hi, thank you. We only know if there is positional obstructive sleep apnea when it's dictated in the polysonogram. So how do we catch these people that maybe the physicians dictate in the reports did not document that it was positional and just gave us an overall AHI?
Let me it looks like we got the lines somehow muted. Okay, I think Emerson and Andrew, your lines have been unmuted.
Mira?
Yeah, we can hear you.
All right, perfect. Yeah, so as a standard of accreditation, most labs should provide a breakout in positional AHI. And if their HST device doesn't, it really would be a conversation with the referring physician to further identify what was captured during polysomnography to see if that patient is a candidate. It essentially would be going back to the provider if it's not in the polysomnography report or the HST report.
I do see that, they'll say supine AHI, so I'm going to take it that is the positional obstructive sleep apnea. But yes, in the HSTs, it does not break that down. So, okay.
Yeah, it depends on what HST device they're using, because some of them do have a positional breakout, some don't. Just depends on what device they're using from an HST perspective and trying to figure that out.
Sure. And again, if I came in late during the session, I apologize. But this is a cash-only item, not billable to insurance, and they can use their HSAs, you said, to purchase this with a prescription. Is that correct?
That is correct.
All right. Thank you.
Uh-huh.
All right. Does anybody
go ahead. I also saw online there's a comment, what is the cost? Definitely we want to work individually with you to discuss costs and what the opportunity is, availability for your business. Definitely reach out to us after this, and we'll take those conversations offline. Feel free to email either Emerson or myself or like Emerson has suggested, if you're aware of who your local Respironics representative is, we can actually coordinate through them as well.
Perfect. Anything else? All right. Thank you all again, and we look forward to hearing from anybody who has any further questions. And again, thank you very much to Andrew and Emerson.
Thank you, Rose.
Thank you.
Thank you.